Hello, I'm Dr. Anne Mary Montero. I'm assistant professor with the IU School of Medicine, and I'm honored to be here today as part of the symposium on chronic pain. So with thanks to the organizers and my fellow presenters, I appreciate the opportunity to be here with you today. I would offer, if anyone has questions during the course of the presentation, they've let me know that you can submit questions or thoughts. I welcome your comments anytime by using the chat box just underneath the viewer, and I'll look forward to Q&A after the presentation. So thank you. I have no conflicts of interest to declare. I have my primary work role at IU School of Medicine, IU Health. I am a medical psychologist with more than 20 years experience working at that intersection of health and psychology, which is a fascinating opportunity to see patients when their needs are typically more overt, presenting with some acuity, typically on the medical side, but often, of course, with psychological comorbidities. I previously worked as a neuropsychologist, both in testing and treatment, including preoperative risk stratification, directly with pain management team, including my esteemed colleagues at IU Health. Helped develop some interdisciplinary coordination in terms of program development. So I'm honored to do that now in a kind of a hybrid role, but still with some direct clinical care. So I appreciate the opportunity to speak from both perspectives today. So this is a fascinating kind of juncture here. It's almost a frontier kind of mentality as psychological variables, psychological interface is being integrated in multidisciplinary settings. Increasingly, of course, we would want to look to data to help guide our decision making and look to examples of colleagues in parallel divisions as to how they are integrating care. So today I would look forward to discussing chronic pain and psychological factors to consider in assessment and treatment of this in the context of a couple of helpful models. We'll look at a few of those theoretical paradigms in brief, specifically identifying one of my favorites, the biopsychosocial model, and its implications for patient care, as well as mental health for patients, their medical realities, and then the social and behavioral context, including, importantly, legal and ethical considerations, as well as patients' own behavior and their role in health stewardship. We'll touch on guidance from the CDC and the body of psychological literature to help identify treatment and assessment, of course, approaches with empirical support, and highlight areas for future research as well as for practice tips. So let's set the stage first with some awareness of the context. Psychological needs in the United States are profound. At any one moment, the body of literature tells us that 1/4 of the population would meet clinical diagnostic thresholds for mental health needs. And over the course of our lifetimes, almost half of us would qualify for a diagnosis with significant associated cost. And I'm always astounded when I present these statistics. According to the WHO, the associated morbidity with mental health needs is greater than that for homicide or war. And among developed nations, mental health needs are the leading cause of disability. So that outpaces medical challenges, including chronic needs. One other important statistic I always include, kind of setting the stage for this discussion, is that medically unexplained symptoms constitute approximately half of what physicians are seeing in their clinics. In other words, we don't have full etiology able to be identified for what patients are experiencing. And in that spectrum, fortunately, we have in the roster for the conference someone speaking on somatoform disorders. But in that spectrum, we would want to sort out the nuances of that, which are subtle and varied, so very important to consider. Of course, psychological factors are relevant whether or not we have medical etiologies identified, but it's important context. Patients with mental health needs fortunately present themselves readily for medical care. They show up for medical care approximately twice as often as those without mental health needs, and at much greater rates of healthcare utilization and cost, on the order of 2 to 1 for specialty care, 4 to 1 for ER utilization, about 3 to 1 for inpatient costs, and 2 to 1 for outpatient costs. So they are, again, fortunately making themselves readily available for our support. Mental health has enormous impact in multiple arenas, including cost to the healthcare system we just touched on, as well as patient productivity, so impact in their own lives, kind of goes without saying, but looking at some statistics for this briefly, impact, for example, on work attendance is significant for mood disorders alone, again, outpacing any chronic medical disease. So that means depression keeps people away from work more often than, say, diabetes. We have some $50 billion estimated in known costs through lost productivity alone, and then some 3 times that estimated in unknown or underdiagnosed and undertreated conditions. So in other words, if we can identify and support, we estimate about a quarter of that patient population or patient need, we can recognize that the scope of the challenge is enormous in terms of both medical and psychological overlap. Some overt identification of pain proportions, I'm sure lots of people will touch on today. Early health psychology data suggests pain accounts for about 80% of all medical visits, so 4 out of 5 patients have some degree, some component of pain included in their physician visit discussion. And almost half of the US and 46% of adults in the US report they have had chronic pain at some point in their lives. So this is a well-known, unfortunately, experience for many people. There are significant correlations with a number of concerning problems grossly affecting patients' well-being. These include depression, and these statistics, by the way, are just tremendously significant. Some 75% of patients with pain would meet diagnostic thresholds for clinical symptoms. Nearly 60% report decreased quality of life. Of course, that's intuitive. Their ability to enjoy life is diminished. 70% report concentration problems, and almost 3/4 report problems with fatigue and low energy. 86% also endorse poor sleep. So we can see pain zaps people with a huge cost in terms of having widespread negative effects. And a very important concept to put on the table with this is the idea of catastrophizing. This we'll get into a little bit more later, but this is cyclical reinforcement, meaning what is a problem becomes more of a problem. People anticipate cognitively aspects of a situation or circumstance that they expect may get worse and focus on parts of that they expect to be the worst of the worst potential outcomes. And then that kind of is like a snowball rolling down a hill. So unfortunately, catastrophizing or focusing on that worst possible outcome is a frequent dimension of anxiety, and it's associated with poor outcomes among patients with chronic pain. So thinking the worst is associated with getting worse outcomes and associated with increased levels of both depression and anxiety. Again, these are intuitive experiences we might expect patients to be having understandably, but something we'd certainly want to be aware of to help support them in. We have a few models to map this out. This intersection, I think, can be described in a range of ways, simple to complex, and I'll usually start off with patients by describing this as simply a Venn diagram with 2 major overlapping circles, with having one side medical dimensions, another side psychological, with an expected overlap there in that intersection between the 2. I always emphasize expected, with an opportunity to normalize for patients. This is part of how we are all wired. Our bodies have pathways for all of us, and I always emphasize for patients that means for you, for me, for their referring physician, for their partner, that would normally offer them an experience of having kind of like a 2-way arrow between their medical and psychological experiences. But then it gets a little bit more complex. And in addition to that basic kind of expected overlap, which of course would then be informed further by physician-identified medical contributors, psychologist-identified psychological contributors, and patient-identified features on both fronts. We have some ways to kind of identify further the synergy that occurs when those two overlap. So the diathesis stress model I find really useful here to capture that interaction. On the X and Y axis here, you could map actually a number of variables. Here we have environment or behavioral exposure interacting with outcome. You could also, I usually explain this to patients with a kind of, I hope, straightforward example like skin cancer. I may have a genetic predisposition by virtue of my heritage to have fair skin and freckles. You're going to combine the likelihood of an outcome for skin cancer of my genetic loading with my behavior of exposing myself to the sun and my degree of use of sunscreen, et cetera. So you'd have a behavior plus an innate loading kind of interaction. You could use this kind of paradigm to put multiple variables on the X and Y axes, like medical and psychological factors, cognitive and behavioral, even expectations and outcome, which I think is especially useful when we talk about patient-physician or patient-provider relations in any discipline. But my favorite of all of the models is the biopsychosocial model, which is a mouthful, but really important as a way to conceptualize our understanding of the human experience, incorporating more factors than the old medical model. It's kind of an outdated, primitive way to describe things being either physical or not, which led to or possibly contributed to some significant stigma that some patients continue to experience. As many of you probably know, on the biopsychosocial model, we account for human experience in that inner overlap with contributors from each corner of the triangle. So here you'd look for in the upper left, the biological contributors. So here we'll find patient medical experiences, their perception of symptoms. You could put medications here, maybe even diet. Up on the upper right, psychological experiences, I would break into two main categories, cognition and emotion, so thoughts and feelings. And then the last corner, social, I break into inner and outer dimensions. So inner being, well, let's start with outer. The obvious part of social is your relationships. I would broaden that to include work. Things in our environment people might put under the rubric or heading of stress. So external things that affect you, and then the inner component to that is our own behavior, how we are responding to what's going on around us, within us, in terms of our thoughts and feelings, and also our medical realities. So all three of these not only intersect together, but you could also draw two-way arrows around that model between each of the corners. And I'll usually describe this, for the sake of time I'll be brief, but I usually map this out for patients individually with chronic pain, beginning at the medical corner, kind of a supposition without getting into the chicken and the egg argument of how it began, but just acknowledging pain is there. With that pain, what kind of mental and emotional experiences tend to accompany that, as well as what kind of behavioral experiences and how that maps onto someone's functioning in terms of their role participation, their ability to work, their relationships, how they're viewing themselves, and then how that behavior in turn impacts the rest of the model. So in short order, we begin to describe the synergistic effects among those such that we can both identify normalized components, what we would expect every human being to experience around that triangle. For example, the arousal with the fight, flight, or freeze response. That's something that occurs in nanoseconds without our intentional engagement. But other components are opportunities for us to engage or reframe different responses so that we can then kind of create off-ramps from what could be conceptualized as like the recycling arrows going in a circle, or on a three-dimensional plane like a tornado ramping up. So this, I think, is really important for patients to understand so that we're all on the same page, and I hope it helps them feel empowered. So I map this out with every patient at the beginning of our treatment together for chronic pain. I'll only briefly touch on some neuropsychological substrates. to chronic pain, but I want to just super briefly point out some fascinating research regarding the stress response. First of all, this goes without saying, the brain, our perception mediates all of our experience, right? It's all filtered through the brain. So what we perceive, what we're focused on, has a great deal to do with how we react, and therefore our perception of experience or symptoms and its outcome. With that, the fight, flight, or freeze response is engaged, as I mentioned, in nanoseconds and is minimally discriminatory, occurring whether stimulus is imagined or real, emotional or physical, immune-mediated and internal, or palpable and external, and has, regardless of those sources, wide-ranging effect across the stages of stress, with risk associated, of course, with chronicity of symptoms. And this response, interestingly, is elicited by both fear as well as pain. So the same anterior cingulate cortex pathway is lit up both when patients are, all human beings are both afraid, fearful, and in physical pain. And it's directly influenced by emotion. At this intersection, we call it psychoneuroimmunology, how kind of maybe non-tangible concepts map onto our tangible experience, like having a broken heart can be correlated with physical injury or physical manifestation of distress. I find this to be one of the most fascinating arenas of our work and our world, and I'm sure we'll have much more to say about this in 50 years. But at this point, we can at a minimum say we know that the stress response will change inflammatory markers in the brain, which elevate pain perception, unfortunately, and fogs our mind. I'm currently participating in an R01 study on this when people are experiencing some cognitive changes, in part possibly from those inflammatory markers. And essentially, we typically have a further stress response. So like I described those recycling arrows previously, we would expect this pathway to be further ramped up and exacerbated by both fear and sensation of pain with some catastrophizing dimensions. How do we manage this? The biopsychosocial model gives us a map, and when it's followed, even in a few aspects, we can see reliably that distress becomes reduced. We can impact emotional symptoms, depression, anxiety, as well as patient participation in medical care and associated costs. In fact, we know that psychological treatments are effective in decreasing many types of pain. Sometimes it has been psychological treatments in general have been demonstrated as the only effective treatment, for example, with functional chest pain. I could present on this all day, so I'm going to move through this section quickly for the sake of time, but studies have shown a number of factors associated with these experiences. Briefly, worsened pain perception associated with catastrophizing, increased perception of negative pain effects. When patients have functional diagnoses, meaning we don't fully understand the medical contributors or can't fully map that. And there may be, by the way, some studies suggest some genetic or phenotypic reactions that may underlie sensitivity to both pain perception as well as potentially response to opioids, but being mindful that that does not necessarily correlate to abuse. We have separate specific research on correlates to abuse that have their own footprint in the literature and require separate assessment. So I outline a few of these here. For example, current depression diagnosis, history of depression diagnosis, history of admission to inpatient psychiatric care, and some access to or personality features, as well as significant trauma history. Most physicians are probably aware of adverse early childhood events, meaning some form of trauma, commonly sexual abuse, that can contribute to some altered, let's say correlate with altered pain perception or medical challenges, unfortunately, later in life. Some behavioral problems also are correlated with risk of abuse. I outline a few of these here. And medical history, of course, there are correlates, including more frequent hospitalization, healthcare utilization on an outpatient basis, having functional limitations, and specifically reporting high fatigue has been associated with that. Societally and demographically, we can identify patients who, an interesting study showed, who report discriminatory experience in the last year. Folks who are adolescent and lower SES have higher overlap with patients who have opioid use disorder. Current substance use, including current smoking and then co-occurring use of opioids, benzodiazepines, or initiation of prescription drug misuse at a very early age, unfortunately also has overlap. We have a higher prevalence among a male population. For the sake of time, I could present on this at length, but let me just kind of show these slides briefly. They're self-evident here. So I would just add with this awareness that we want to be cautious about use of our clinical judgment and aware of our own biases. We know from cognitive psychology that we are prone to judgment errors with principles of cognitive dissonance. For example, we don't like to have dissimilarity in what we're thinking and feeling, for example, and commonly in patient assessment, I will search for that very factor dissonance or discrepancies in presentation when doing validity assessment. So something to be paying attention to on patient presentation fronts as well as our own beliefs and how we're being stewards of that as we're utilizing our clinical judgment. And in terms of opioid misuse, let me just touch on briefly here the rates. This is also self-evident, acknowledging that self-report data is higher when patients are asked about any use of opioids different from that which was prescribed. I would add that this is dwarfed by mental health challenges overall, with particular emphasis on the risk of self-harm with suicide. So here's a visual way to kind of line up these risks side by side. So, and hopefully mental health challenges are coming into increasing focus, both in their own right as well as in light of other medical needs, including chronic pain. And relative to preventable deaths, this was done without respect to COVID, so we're not delving into that today, but just independently looking at this in the context of overall preventable death or poor outcomes with behavioral components, including suicide. I wanted to line those up side by side for your consideration as well. So, with all that awareness, how can we use this to guide us? Of course, we want to be referencing empirically supported information for assessment and treatment. So building on these factors to be mindful as we assess someone's heightened attunement to or risk for both pain perception and potential response to treatment interventions. I pay particular attention to validity assessment, both in form and content, when I'm looking at this with patients, and I think this is an important conversation in turn when we discuss stigma, which I understand, fortunately, we have very esteemed presenters speaking on the agenda directly to that issue. But it's important, I think, to look at patient presentation. I mentioned previously looking for consistency, as well as how their report and their clinical presentation maps out with places that we can have objective data. Of course, we would want to be collecting and comparing as well. So this is routine in other fields. I work among the rest of these populations as well. So in women's health, psycho-oncology, we routinely not only include psychological assessment and treatment, but it's formally recommended by their governing or leadership bodies. And similarly, psychological factors are included in WHO steering group pain guidelines for assessment and treatment. At least psychological factors should be included in assessment, and psychological treatment is overtly recommended, noting that patients may underreport the possibility of chronic pain and they suggest we may be at risk for under-detecting chronic pain. I would again refer to my esteemed colleague who will speak on stigma as a component to that. You're probably all familiar with CDC guidelines. I would overtly outline these here and point to the important use of incorporating data informing us of patient behavior, including in Indiana, the INSPECT report, patient healthcare utilization, and objective evaluation of their condition medically as well as psychologically, if you have that available, as I do in partnership with my pain colleagues at IU Health. So from the American Pain Society and American Association of Pain Management, there are guidelines recommending a balanced approach with awareness of risk-benefit analysis and comparison. So bottom line, we would assess risk including factors relevant to potential for potential treatment misuse with awareness of psychopathology, as well as more subtle factors like identifying secondary gain. Back to that slide I had before with the Venn diagram of medical and psychological factors. In that overlap there, I mentioned somatoform disorders, which is not a singular type of disorder. And again, we have someone speaking on this today. But just quickly, I think of this as a spectrum from normal adaptive response that might be classified under an expected adjustment disorder, for example, in our lexicon. So someone who's dealing with predominantly medically identified etiology for chronic pain or acute pain, and who is having an understandable or expected negative emotional response to that. I would think of that then on a spectrum to increasingly less adaptive and less robust coping, all the way down to more intentional patient focus on symptoms, even maladaptive symptom exacerbation or even elicitation, and other maladaptive coping like substance use. So I think of that on a spectrum, again, from normal and expected to less adaptive. And we would want to assess that together with the more objective data that we have available to us. I would add with the direct recommendations to assess factors of risk, these guidelines suggest these may be helpfully assessed by people who are trained specifically in the assessment and treatment of the very variables that we find correlated with pain perception and challenge with outcomes. So these would logically fall under the domain of psychology, but I would note only one psychological professional was included in the panel of developing these guidelines. So there's an opportunity for increased psychological involvement since these fall under the expertise of those types of providers. I will tell you today we can be extra vigilant to factors that we acknowledge with the literature footprint that can contribute to that overlap. I utilize screeners specific to these. I'll come back to this, but just to outline these briefly. I utilize screeners specifically for, I like the SOAP for this, but for opioid and other substance use risk assessment, a couple suggestions offered here, as well as other validated measures for psychological variables like depression, anxiety, catastrophizing. I find the pain catastrophizing scale really quick and easy to use with patients. In fact, most of my patients I routinely use the PHQ-9, GAD-7, and pain catastrophizing scale with the SOAP for all of my pain patients, and they'll complete that in less than 2 minutes at the most, even for folks who have challenges. Sometimes anxiety can contribute to some reticence to quantify symptoms, but it's pretty straightforward and very brief and easy to verbally walk through if patients have a literacy challenge. If there are malingering concerns or more subtle suspicions on the somatoform spectrum, further malingering assessment would be appropriate. And if there are cognitive concerns beyond the MMSE, we could consider the MoCA or more full neuropsychological assessment. Okay, and then Beyond assessment, multimodal therapy is recommended. So use of psychological interventions has good empirical support, including integrating psychological approaches, showing treatment as more effective, specifically with benefit for chronic pain. So we'll come back to this in detail, but another important point on the CDC guidelines is to acknowledge we expect to see benefit reasonably early if it is likely to show at all. And we would look for symptoms and functional impact to outweigh risk. So again, back to that risk-benefit ratio, we would want to be mindful of both sides of that equation, and including patient perception in an empowered way, likely in your assessment. By the way, we are lacking data on long-term effects of opioid use, and so we're not able to fully quantify the long-term range of risks and benefits in this arena. So this is clearly an opportunity for study and with suggestions of psychological factor inclusion as we look to understand longer range impact of these interventions or avoidance of available interventions. So in summary on assessment, probably reiterated this enough, hopefully you all are aware, but we want to acknowledge the psychological factors that are validated in the literature and merit inclusion in our pre-treatment assessment, as well as be mindful of our own biases and factors influencing our judgment. When we do include relevant risk factor assessment, we can better identify patients who are at risk and therefore hopefully better position ourselves to offer appropriate or matched care, and include potential impact on these features, the pain itself and its impact on functioning, psychological symptoms, patient behavior, including their coping or their tendency cognitively to catastrophize, their cognition per se and their ability to participate in medical decision-making, importantly, their compliance, their healthcare provider relations, and the validity of their report we would want to, again, monitor on an ongoing basis, along with their substance use risk. So I'm sure everyone who's assessing is already doing this, but we want to incorporate my order of operations is just first collaborate with my physician colleagues. They have typically evaluated a patient before they send them for psychological assessment, so I have an idea of what they have assessed to be the medical contributors, back to that biopsychosocial model, what's happening from the biological corner. If there are concern for aberrant behaviors, I would ask for feedback on their inspect report, their use of prescriptions, and any other objective data, for example, the urine drug screen or other tox screen monitoring, and verify appropriate compliance, as well as sufficiently cooperative healthcare provider relations. I used to work in transplant, and this was an overt factor we would call out in our reports because it's necessary for a long-term partnership. Typically, management of chronic pain is not a short-term engagement. So we want to verify that this is not only a functional relationship, but ideally something that's comfortable for interchange on both sides. The patient, I'm sorry, I'm blanking on the term, the patient tools where we outline expectations for a behavioral agreement, I always view as an opportunity to engage patients proactively and help them be aware of expectations. So I always frame that as an opportunity to fairly put expectations on the table for both sides. So I mentioned earlier some of the scales that I use with my evaluation. And once we have the evaluation conducted, it's critical, of course, to have follow-up care coordinated between medical and other interdisciplinary team providers. So recommended, I would say, at onset, during treatment, at key points, depending on those factors we've outlined. For example, maybe in the 6 to 12-month range, more frequent if there is aberrance or some discrepancy, either in patient presentation or between reports to different providers. I will scan the chart to see how symptoms have been presented across different disciplines, so we can be mindful of that as well. And I think we've covered on this sufficiently. Let's, for the sake of time, move forward to talking about integrating care. So psychological treatment, we have good support to help demonstrate efficacy with pain, and we have a number of modalities that we can utilize, cognitive behavioral therapy being kind of our most robust tool, or tool with most robust support, I should say. We also can utilize hypnosis. There are a number of modalities. I'm just hitting on a few here, but hypnosis, relaxation training, I think of this as a subset to CBT. Psychodynamic therapy is an older model. There are emerging third wave, what they call third wave, types of therapy, including mindfulness, ACT or ACT, and other approaches, as well as tangible treatment like biofeedback. So CBT stands for Cognitive Behavioral Therapy. Many of you may know this is our most studied treatment, typically recommended in chunks of 6 to 8 sessions, although it can be effective in shorter blocks. It is our most efficacious and most lasting treatment, or at least has long-standing robust data to support it. Traditionally is the most lasting, although I will add hypnosis has some pretty good long-term data as well. We have data to show this as helpful across a wide range of types of pain symptoms. I included an example or two here. And as I mentioned earlier, it outpaces some medication treatment alone, as well as standard medical care in some cases, and it can be the only effective treatment for some types of pain, like functional chest pain. We can map out its efficacy across a wide range of variables as well. So it not only helps, as you might expect, with psychological variables like depression and anxiety, but it helps with medical variables, as I mentioned, pain as well, visceral hypersensitivity, a wide range of GI symptoms, and other functional outcomes. So it has received a strong recommendation rating from some of those guiding bodies of physician groups, including the ACG. Hypnosis has been receiving increasing attention and support as an empirically supported treatment. I'm always kind of astounded when I present these data, but it is held remarkably well over the long term. It's conceptualized as tapping the subconscious, a way to kind of get under the hood, so to speak, for the patient experience. And for long-term follow-up, patients reported in this study I cite here, 81% gains retained at the 5-year mark. It is very hard to find a treatment that can demonstrate that kind of efficacy and durability. So that is something I have been specifically trained in, and I will add it's especially helpful when there has been some degree of resistance and or trauma in patient histories. But a word of caution on this, I think it's very important to manage discussion of hypnosis in an engagement-oriented way. I think there's an ethical risk because of the prevalence of trauma overlapping with many chronic symptom histories. Patients can run the risk of feeling like something has been, there's an external agent that has occurred for them. In other words, something has happened to them. And treatment is, at least in the cognitive behavioral model, conceptualized as an engagement process where patients are actively learning and helping to do for themselves. Hypnosis runs the risk of having that other model of something being done to them. So I think it's really crucially important to handle discussion of that in a partnership manner to make sure your alliance is very solidly established before you would consider that, and then overtly discuss the steps and what to expect, and assuring patients along the way if they choose to engage in that type of treatment. Relaxation training does not have as robust support as an independent treatment model. This is essentially helping patients engage the brain's relaxation reflex and incorporate that to break up both their physical reactivity to stress, including response to chronic pain, as well as the cognitions that typically are associated with that kind of response and can feed that cycle, like I described, the recycling arrows going in a circle or creating a tornadic effect. We would look for relaxation training as one important tool to help break that down. If we have enough time or during Q&A, I'm glad to walk through a model of when I incorporate all of these. There is some support for psychodynamic treatment. I also looked up some of the third wave treatments. Mindfulness has some variable support. Some studies suggest not yet consistent support or robust. Others suggest good support, but low quality studies. So that's certainly I would put in the category of keep an eye on, because we have good data to show efficacy in other domains. So I am expecting studies will soon be able to demonstrate that here as well. Invasive brain stimulation and non-invasive brain stimulation of the motor cortex showed some significant differences, I should say, between invasive outpacing non-invasive, and then for non-invasive, active treatment had a significant difference or improved response better than sham, so with a risk ratio of 2.64. So we have some data to begin supporting that, but that's not in widespread the mainstream of what we would look to as a first-line intervention by any means. Biopsychosocial rehab, kind of an interdisciplinary model, I didn't outline in my slide, but there's some studies suggesting that when multimodal therapy is included in a very intentional and intensive way. For example, one study showed for disabling pain, having a daily 30-day model, there was strong evidence for functional improvement. So we'll be keeping an eye on that as well, but with awareness, that kind of engagement may be practically challenging for patients, but if their lives have stopped because of pain, having a treatment that requires full-time engagement may be appropriate to consider as well. Briefly, biofeedback has some very strong support, and I have included some specific examples here. For example, anorectal pain, functional abdominal pain. There's not only good improvement, but some ability to hold those gains after time. I have commonly partnered together with physical therapy and sometimes occupational therapy, or partners in speech, for example, together with physicians as we do interdisciplinary care. So having that cross-modality engagement and communication ongoing, not just at the start of the assessment, but as patients are progressing, is a great opportunity to help pull the process together for patients and ideally help them better. So of course we can also employ psychoactive agents to support treatment, targeting both a range of psychological symptoms as well as pain, of course with some efficacy there. So we would demonstrate then that psychological treatment inclusion is not only effective for symptoms across a wide range of categories, but also helping reduce cost and healthcare utilization as well. However, we would want to be mindful that there are some challenges with follow-up. Stigma, I have mentioned before, has been significant, often for patients who have had less contact or less opportunity for psychological care inclusion in the past. I handle that with a very open psychoeducational approach, acknowledging this may not be for everyone. Also recognizing there's a 50% loss to follow-up industry-wide, so meaning for psychological referrals, I remember in graduate school they're telling us 1 in 2 patients won't show up to the very first referral appointment, and then 1 in 2 of those patients won't be expected to follow up for the first therapy appointment after assessment. So recognizing if that's kind of the benchmark in the industry, in our field overall, we may expect with some overt medical challenges that patients may be at increased risk for loss to follow-up. There are also, in different organizations, some limits inherent to having an individual psychologist access, and this may require, of course, additional time for communication, but ideally, this will be assistive for patients. And as we described before, not only assistive in terms of physical outcomes, but also psychological and functional benefit here. So I've covered these. So one last point about psychological treatment. I think that often healthcare providers might have the perception that if psychology is involved, it can be a long process, slow to change. That's very dependent on patient engagement and then the specific contributor symptom-wise. I would acknowledge at times treatment gains can be very rapid, even sometimes occurring in 4 sessions. I've had patients in as little as 1 session tell me that their pain was resolved after describing this as part of the normal process with that biopsychosocial model, or one component of it can be normal. Patients can sustain their gains, and it can be effective across a range of needs, as I use the example here repeatedly of GI symptoms. They can be sustained and efficacious, and I described some statistics here, some studies suggesting up to 70% of medical symptom improvement. And of course, as patients improve on one front, we would hope that that would synergize and overlap with their well-being on other fronts. So in summary, we've touched on models to understand psychological factors affecting patients' symptoms and integrating them in medical care. We've outlined guidelines from the CDC and pain leadership groups, as well as efficacy data and some future research opportunities, which can include longer-term impact of both medical interventions, surgical and non-surgical, as well as specific modalities from the psychological standpoint. And I am just honored to participate today. Thank you so much for having me. I'd invite you again, if you have questions, to submit those with the chat box just underneath the viewer. And I'll happily be available to answer, and I thank you so much again for having me today. Any questions, feel free to reach me here.